Hello everyone, you're watching sqadia.com and now we are on the clinical practice guidelines for rheumatoid arthritis. In this section, we'll be going through the why the initiation of treatment should be needed and how it's done, when to perform surgery and how to control the flare-ups. Why is actually these practice guidelines are needed? As you know that there's not only one person who is involved in the care of a rheumatoid arthritis patient. There's a rheumatologist, there's an orthopedic surgeon, then there are orthotics personnel, then a physiotherapist, then there's an occupational worker and a social worker. So if so many people are involved in the management and the treatment of a rheumatoid arthritis patient, then there has to be a clear-cut role defined. For example, a rheumatologist should know what is within his or her domain, and an orthopedic should know that when he or she has to intervene, and what's the role of an orthotic personnel, a physiotherapist, and occupational therapist in caring for a patient of rheumatoid arthritis. Now, these were developed, the latest being developed in 2015 by the American College of Rheumatology, and these scope of guidelines is to basically address certain pertinent questions regarding the treatment of rheumatoid arthritis. These include use of traditional disease modifying anti-rheumatic drugs, biologic DMARDs, and tofacitinib, which is actually a newer form of DMARD which has been introduced in the market. Then use of glucocorticoids, what is the rationale behind them and how much they should be utilized and when they should be tapered off. Then use of biologics and DMARDs in high risk population. High risk population means patients who had developed rheumatoid arthritis but they already have diabetes, they already have heart failure, they already have pulmonary fibrosis. Now you cannot give them all the drugs because all these drugs have side effects, so you have to tighten the pros and cons of giving these drugs. So these are actually a special category of patients in which the use of DMARDs, how it should be done and how the doses should be maintained is definitely needs special attention. The use of vaccines in patients starting and receiving DMARDs, as you know that the patients may be having different vaccines for different diseases, and if they are on DMARDs or whether they've taken it and now the DMARDs have to be initiated, then there is specific guidelines that how it should be done. Especially important is screening for tuberculosis, because we know that the use of glucocorticoid it's very important in control of inflammation and swelling of the joints. But as steroid decrease the immunity of the body, resulting in if there was some latent tuberculosis, especially which is very common in these Mediterranean countries and in South Asian and Asian countries. And for example, a patient who is of a Pakistani or Indian origin and is at the moment in the US, settled in the US, if he is taking steroids and there was some degree of latent tuberculosis was present, this may result in a flare of tuberculosis, and this can even cause a pandemic in that area. So that is important that tuberculosis has to be ruled out properly because steroids have to be initiated. Then the other includes the laboratory monitoring for traditional DMARDs, when to do the laboratory monitoring in what type of populations. Now, different criteria define remission differently. Now, this is something which is very important because as we know that it's kind of a disease which is a slowly progressive kind of a disease, which if you cannot really completely treat it, but you have to manage it accordingly. But there are different, for example, there is patient activity scale, critical disease activity index, disease activity score, and simplified disease activity index. They have defined a different criteria for remission. That is that if they fall into this criteria, that means the disease has decreased its activity to such a low extent that they can be termed as that they have got rid of the rheumatoid arthritis. Now, what are the treatment guidelines in early rheumatoid arthritis? And now remember these, regardless of the disease activity level, use treat to target strategy rather than a non-target approach. If the disease activity is low in patients who have never taken DMARD, start with a monotherapy. That is, start a DMARD straight away, especially methotrexate over a double therapy or triple therapy. Now, double therapy means combining methotrexate with sulfasalazine, and triple therapy means combining with hydroxychloroquine and sulfasalazine. But usually, DMARD monotherapy is preferable and it should be started as early as possible. If disease activity is moderate or high in patients who have never taken a DMARD, use DMARD monotherapy over double therapy and over triple therapy. The same thing is that whether it's low, moderate, or high, we have to start disease modifying anti-rheumatic drugs. If disease activity remains moderate or high despite DMARD monotherapy with or without glucocorticoids, use combination DMARDs or TNF inhibitors or non-TNF biologics. Now, this is something if there is a high activity and the patient has been initiated with DMARDs. Now, there are two ways. If methotrexate was already has been initiated, what we can do is we can switch to methotrexate plus sulfasalazine or hydroxychloroquine. And another option is to keep giving methotrexate and start anti-TNF inhibitors or non-TNF inhibitors, which include which are interleukin 6 inhibitors, B cell modifiers, or T cell costimulation drugs. Now, recommended for the patients with symptomatic early RA. Now, other include use of tumor necrosis factor inhibitor monotherapy or tofacitinib monotherapy, because although tofacitinib is a new drug, but still, if we have to give only tumor necrosis factor inhibitors, then TNF anti-TNF inhibitors have a role are better than use of tofacitinib. Use of tofacitinib inhibitors plus methotrexate over the important point is that combining methotrexate with anti-TNF inhibitor is better than combining methotrexate with tofacitinib. If the disease activity remains moderate or high despite a DMARD or biological therapies, add a low dose glucocorticoids. Now, if the patient comes to you, what they're trying to tell you is that if there's early RA, you start DMARDs, that is methotrexate. If its response is good, well and good. If not, then the two ways to do it. That either you combine methotrexate with sulfasalazine and hydroxychloroquine, or you combine this methotrexate with TNF inhibitors. Then the TNF inhibitors and methotrexate combination is better than the methotrexate with tofacitinib inhibitors. But if we have already combined methotrexate with TNF inhibitors and response is still not good, then the third line of treatment could be the use of glucocorticoids. If disease flares, in case of flares, if a patient was having a okay time, she was taking methotrexate and TNF inhibitors, but suddenly there was a flare up of a disease. There was increased swelling, increased congestion and vascularity, and increased pain and stiffness. Then during those flare ups, glucocorticoids are the ideal choice of treatment because they reduce inflammation and swelling of the joints, especially during the flare ups. Now, this is an activity chart which is showing how to treat an early rheumatoid arthritis patient. If you see it over here, this is low disease activity, it's DMARD monotherapy, which is methotrexate. This has to be combined with TNF inhibitors or non-biological TNF plus methotrexate. If still keeps high, then we can either start glucocorticoids or we have to switch to the algorithm for established rheumatoid arthritis. Now, if a patient has already established rheumatoid arthritis, what are the recommendations for those patients? These includes, regardless of the disease activity, use treat to target strategy. If disease activity is low in these patients and who have never taken DMARD, use DMARD monotherapy as in the earlier rheumatoid arthritis. If the disease activity is moderate or high, the patients who have never taken DMARD, use DMARD monotherapy over tofacitinib. Use DMARD monotherapy over combination of DMARD therapy. Similarly, whether it's an early rheumatoid arthritis or an established case, you have to start with DMARD straight away. Then most preferable drug is methotrexate. If disease activity remains moderate or high, despite DMARD monotherapy, use combination traditional DMARDs and add a TNF inhibitor or non-TNF biological inhibitor or tofacitinib. All choices with or without methotrexate in no particular order of preference rather than continuing DMARD monotherapy alone. The important point is you cannot leave out methotrexate or DMARDs. You have to add DMARD and then add them with either TNF inhibitors or non-TNF or tofacitinib, but cannot start with TNF and tofacitinib straight away without adding DMARDs. If the disease activity remains moderate or high, despite TNF inhibition therapy in patients who are currently not on DMARDs, add 1 or 2 DMARDs to TNF inhibitor therapy rather than continuing TNF inhibitor therapy alone. Now, other includes if the disease activity remains moderate or high despite use of single TNF inhibitor therapy, use a non-TNF biologic or without methotrexate over TNF inhibitor with or without methotrexate. If the disease activity remains moderate or high despite use of single non-TNF biologic, use another non-TNF biologic with or without methotrexate. Now, in case of established rheumatoid arthritis, if there is a high activity, then there's slightly different that we have to, instead of starting with the DMARDs and then moving to non-biologic and TNF inhibitors, we have to straight away, in an established case of rheumatoid arthritis and with high disease activity, we have to straight away jump to first tumor necrosis factors inhibitors or non-TNF biologic drugs. Now then they can be, if still the activity is high and there's no real response, then we can combine them with methotrexate. But then in case of established RA, and in case of high disease activity, the first choice of investigation are TNF inhibitors or non-TNF biologics. Now, recommendations again being continued for the established rheumatoid arthritis. If the disease activity remains moderate or high despite use of DMARDs, TNF inhibitors, or non-TNF biologic therapy, add short-term or low-dose glucocorticoid therapy. If the disease flares in patients on DMARD, add a short-term glucocorticoid at lowest possible doses and shortest possible duration. This is a very simple phenomena that if there is an established RA and high disease activity and patient is already taking methotrexate, already taking TNF or non-TNF inhibitors, then to deal with the flare-ups, you have to add glucocorticoids. If the patient is in a remission, then as per the remission criteria, taper DMARD therapy, taper TNF inhibitors and non-TNF biological therapy as well. Now, why we need to taper that? Because this methotrexate is not a kind of a drug which has a very low side effects. There is a very high amount of side effects of methotrexates. So even these drugs itself have a lot of side effects on other organ systems. So if the patient has fallen in the criteria of remission before it restarts or relapses, then we have to taper the DMARD therapy. If the patient disease in a remission, do not discontinue all rheumatoid therapies. Now this is important. You cannot completely give away with drugs because this disease is not something which is going to just go away and you can completely treat it. In remission means there is the activity of rheumatoid arthritis is so low that it's not actually progressing at a very high rate, but that does not mean that it is actually progressing. So this is the algorithm for established rheumatoid arthritis, and if you see it over here, the only difference is that in low activity and moderate activity and in established case of rheumatoid arthritis, the first choice is DMARDs, then the TNF inhibitors, and then the glucocorticoids. But in case of moderate to high activity, the first choice is basically non-TNF or biological TNF inhibitors, and then the methotrexate and other DMARDs, and the third choice is glucocorticoids. Now, how to monitor them, especially if we are giving them methotrexate, and if we are giving them, especially the most common drug which is usually given is the methotrexate, and if the patient is taking it for less than 3 months, then we need to repeat the baselines at 2 to 4 weeks. If the patient is taking it for 3 to 6 months, Then we repeat to repeat all the baselines of the patient 8 to 12 weeks. If the patient has been taking of greater than 6 months, then at 12 weeks, that is after every 3 months, all the baselines of the patients have to be repeated, so to monitor the side effects of the methotrexate on body. In certain patients, for example, a patient with chronic heart failure, Hep B, CLD, patient of myeloproliferative and tumors, now these are high risk patients or special populations. In that case, or in case of CHF, that is congestive heart failure, use combination DMARDs, a non-TNF biologic, or tofacitinib over TFN inhibitors. Now that's important because the TNF inhibitors have very high the side effects, especially they affect heart more than other organs. So non-TNF biologics or DMARDs are ideal choice. In case of congestive heart failure worsening or current TNF inhibitor therapy, then you have to switch to non-TNF or use of other DMARDs. Rheumatoid arthritis in Hep B patients. Now, they could be patients who have active Hep B infection or could be latent Hep B infection. In case of active Hep B infection, same recommendation as patient without this condition, which means that you have to start with DMARDs initially, then move to TNF, and if still the disease is progressing and there's no low response, then move to glucocorticoids. Now, in case of malignancy, if the patient has been treated for some kind of skin cancer, then the DMARDs are the first line over biological, or which is the TNF and non-TNF inhibitors. If the patient has been treated over for lymphoproliferative disorder, the rituximab is the choice over TNF inhibitors, which is actually B cell modifier. Previously treated lymphoproliferative disorders, in then case we can start with DMARDs, then TNF, and then glucocorticoids. Now this is something which is very important. If the patient has previous solid organ malignancy, same recommendation goes for all type of malignancy. That is the first DMARDs, then the tumor necrosis factors, and then the third choice is the glucocorticoids. Thank you very much. Keep watching sqadia.com.